With Dr. Narendra Singh VERMA to please present, and we would like to congratulate him. He got the ARC first prize for this same very topic. So congratulations, Dr. Narendra. And he'll be speaking on image guided systems and Toric IOLS. Dr. Narendra Singh VERMA, please.
The outsider, and thank you, Sinha sir, for including me in his IC. So, image guided system and Toric IOLS. If we see the prevalence of astigmatism in cataract patient, about 26% of the patients, they are having astigmatism more than one diopters. So they are the best candidate for toric lens implantation. Out of every 3 or 4 patients, we can advise them for the toric lens implantation. So if it is not corrected, astigmatism is not corrected, in photopic condition, it causes double vision, blurry vision. In mesopic condition, it causes halos and glare and streaky lights. So if we see these are the potential source of error during toric lens implantation other than the non-toric IOL implantation. So we will deal with the preoperative about the marking, how we can prevent the cyclotorsion error, how we will deal with the SIA, and intraoperative, how we can prevent the rotation of the toric lens. So which part of astigmatism is corrected by toric lens? We are able to measure anterior corneal astigmatism very precisely now. Then we have to measure the posterior corneal astigmatism, or we are using the predicted value based on the Baylor nomogram. Anterior and posterior will give you the total corneal astigmatism. When we are taking incision on the cornea, it will induce some SIA. So SIA with TK will give you the net corneal astigmatism, and toric lens are supposed to neutralize this net corneal astigmatism totally, then only we'll get the eumetropia. At present, we can measure anterior, but for the PCA, posterior corneal astigmatism and SIA, still they are not measured precisely. So about the posterior corneal astigmatism, it is about 0.26 to 0.78. It is steeper vertically, so it is being a concave lens, it is inducing against the rule astigmatism. Dr. Douglas Koch gave us Baylor nomogram. This is the slide which everyone should know, remember, that when the anterior corneal astigmatism is with the rule, posterior is there, some amount of posterior is there which is against the rule, so the total is decreased, total astigmatism is decreased, so we have to correct with the rule astigmatism slightly lesser. And when it is against the rule, anterior corneal astigmatism is against the rule, posterior is adding into it, so the total is increased, we have to overcorrect, or we have to deal with ATR more, we have to overcorrect it. Then this type of, this is the Barrett toric calculator. We need not to calculate the posterior by the Baylor nomogram, it is incorporated in these type of calculators. This is, in the previous talk, it was told that in the young age, we are having anterior corneal astigmatism with the rule, and as the time passes, it changes to against the rule. So we have, in the young patient, if they are having with the rule, we have to undercorrect it because it is going to change against the rule as the age advances. About the SIA. So SIA calculation, SIA measurement is not very precise. So Dr. Graham Barrett, his advice is that you have to try to minimize the SIA as much as possible. Go for the incision which is 2.4 millimeter or less than that, and use the SIA value 0.1 diopter. For incision which are more than 2.8 millimeter, use the SIA value 0.12 diopter. In individual cases, though it may be SIA may be 0.4 or 0.5, but the standard deviation is less. So in majority of the cases, you can use this value and it is working properly. If you want to calculate your centroid SIA, you have to go for the Dr. Warren Hill SIA calculator, or you can use our SIA calculator, which is better, which is easy to use, and you can scan this QR code. So this is our SIA calculator. So there are two methods for the markings. One is the manual marking method, second is markingless method. So in the manual marking method, you can use this bubble marker, pendulum marker. These are some digital markers, very costly, and these are electronic markers. They were used before the invent of the markerless system. They are based on the 3-step method, so there are chances of error. So to eliminate this error, a lot of doctors worldwide they have invented some mobile apps. So the mobile app, they can eliminate the cyclotorsion error, but they can't eliminate the head tilt error. And there are two types in which the reference marking are required. In some reference marking are not required. So this is Toric error and the Toric this app by Dr. Saurabh Patwardhan. So in this app, manual marking is required preoperatively. These are app by Toric app by Dr. Graham Barrett and Precision Toric app. These two apps, in this the manual marking is not required because they are considering the limbal blood vessels for the marking. This is the Toric IOL axis marking app by Dr. Jetwa. This is by Dr. Sahil Chaudhary. So nowadays we are having this marking system. They are of Callisto, Varion, Aura, and on few are in the pipeline. This Aura is intraoperative marking. So after removing the cataract, you can by aberrometry you can measure the toricity and the spherical power. So these are the apps, intraoperative mark, this Aura and this image guided system. They can eliminate the head tilt error because they are measuring and they are marking at the same time. So they are single step method. So I will show this. I will show you the some intraoperative tips. Just 1 minute waiting. Volume. Volume नहीं. Volume is not there.
थोड़ा आवाज बढ़ा दे.
नहीं चालू ही नहीं हुआ इसमें.
नहीं इसमें वॉल्यूम इधर प्ले कर दो क्या?
इधर हो जाएगा प्ले कर दो वीडियो प्ले.
ठीक है, बिना साउंड के चला दीजिए. टाइम का ये.
So I will just tell. So the size of incision should be proper. If they are leaky incisions are there, then the lens can rotate. So then the CCC should be smaller and central. So if you are not having high-end instrument, you can use this marking method, marking on the cornea. This is also effective. The CCC will be central. Then the complete, you can hydroimplant the toric lens. If you are confident, it is very easy. Just there is initial glitch. Then you have to remove the viscoelastic from anterior and posterior surface. After removing, we have to nudge the lens on the posterior capsule slightly so it will not rotate. Then don't overinflate the AC. If you are overinflate the AC, mainly in the myopic cases, it will rotate. Remove the speculum slowly. You should not decompress the anterior chamber and use hydrophobic lenses, acrylic lenses, which are more stable. Thank you.
Thank you so much for your wonderful presentation. Thank you so much. It's so enlightening.